Today, 2015 proves to be a banner year for FDA approvals in cancer, and a preview of the upcoming GU Cancers Symposium. Hello and welcome to OncLive News Network. I'm Laura Jones. Let's begin with a look back at 2015. There were 15 new molecular entities approved for cancer indications by the FDA in 2015, representing a substantial increase over the 9 approvals in 2014. 4 of last year's approvals were in multiple myeloma and 3 were in lung cancer. Counting new indications for already approved molecules, there were 32 cancer-related approvals in 2015 versus 19 in the year prior. The immune checkpoint inhibitors were responsible for boosting the overall numbers, with several approvals granted to ipilimumab, nivolumab, and pembrolizumab throughout the year. Upcoming FDA decision dates include approvals for maintenance ofatumumab in CLL, carfilzomib in relapsed myeloma, and frontline nivolumab in BRAF mutant melanoma. Abstracts were published this week for the upcoming Genitourinary Cancers Symposium. At the meeting, we can expect to hear updates from the celecoxib arm of the STAMPEDE trial and new data on atezolizumab in bladder cancer. Also, Phase 2 findings for a chemoimmunotherapy triplet in urothelial cancer and new data with an HDAC inhibitor in RCC. Additionally, prior to the meeting, ASCO spotlighted 3 studies through a presscast. One study was a subgroup analysis of the Phase 3 METEOR trial in which cabozantinib significantly improved progression-free survival versus everolimus in patients with renal cell carcinoma. This was regardless of the degree of metastases, type or number of prior treatments, or patient risk status. The updated progression-free survival data for all 658 patients reported on the presscast were comparable to the interim data, 7.4 versus 3.9 months. In patients with at least 3 metastases sites, the median progression-free survival was 7.3 months versus 3.7 months for cabozantinib versus everolimus, respectively. Further, the hazard ratio for progression-free survival favored cabozantinib across metastases sites, including lung, liver, and bone. A second study showed that men who took regular aspirin had a lower risk of developing a lethal form of prostate cancer. This observational study also found that among men already diagnosed, those who took aspirin lowered their risk of dying from prostate cancer by 39%. After adjusting for differences in age, race, body mass index, and smoking status, men without prostate cancer who took aspirin regularly had a 24% lower risk of developing the disease. However, regular aspirin use before diagnosis did not confer a measurable benefit for the prevention of overall high-grade or locally advanced prostate cancer. And the final ASCO GU previewed study showed that a circulating tumor cell blood test could help detect which patients with prostate cancer are most likely to be resistant to hormonal therapy. Overall, patients with higher heterogeneity scores did not respond well to hormonal therapies compared with patients who had a low score. Those with a high score had a shorter median progression-free survival, 5 months versus 17 months, and overall survival, 9 months versus not reached, compared with patients with low scores. In contrast, heterogeneity scores were not associated with taxane resistance, suggesting those with higher scores could be candidates for chemotherapy versus androgen therapy. Be sure to view next week's program when we highlight data presented at the ASCO GU conference. And that'll do it for today. Thanks so much for watching OncLive News Network. I'm Laura Jones. We'll see you next time.